Right, okay. This time I would like to talk about clozapine and schizophrenia and give some advice and yeah, see how it goes. So clozapine is a second generation antipsychotic. It's chemical dibenzodiazepine, and it was introduced in the mid 1970s. Initially, it was given in Finland and other Nordic countries. And there were 7 people who died of this. And the reason why they died is because clozapine caused fatal agranulocytosis. So agranulocytosis is the complete blocking of the development of white blood cells. So then this was taken off the market. However, some people felt it was a very promising medication, especially in patients who were treatment resistant with other medications or had severe side effects. We should consider at this time there were first generation antipsychotics like haloperidol, which had lots of side effects at this time and weren't always a medication of choice. Right. So for that reason, the clozapine has been reintroduced. However, with the recommendations that doctors and patients who are prescribed this medication are registered with a specific agency, and this agency then has to regularly check the white blood cells and to check for neutropenia, and to make sure that only patients who don't have side effects can be prescribed this medication. There have been several studies, and in all of these studies, clozapine has been shown to be very good, superior to most of the antipsychotics in positive and negative symptoms. Positive symptoms in this respect are the patient's symptoms like hallucinations, feeling of prosecution, hearing voices, seeing things which are not there. Negative symptoms are the symptoms that are lack of drive, lack of motivation, lack of interest. So a very withdrawn type of psychosis. Right. Okay. So if patients haven't responded to 2 or 3 antipsychotics, which at least one should be from the newer second generation antipsychotics. Second generation antipsychotics are olanzapine, quetiapine, amisulpride, aripiprazole, and risperidone. So if they haven't responded to that, then one could justify trying clozapine. The question is sometimes, that other people would say, and I would possibly go with them, that there's so much of variation and different efficacy of second generation antipsychotics that possibly in the younger patients, at least, I would possibly try to try more than 2 antipsychotics from the second generation antipsychotics. Anyway, so there's some discussion about that. However, even then, if there is no response with clozapine on its own, it can be combined with other antipsychotics such as aripiprazole or amisulpride. However, these recommendations are more or less from day-to-day work, and there are no good studies about them. So let's say it that way. The NICE guidelines recommends that people who have schizophrenia, who haven't responded to at least 2 antipsychotics, should be tried on clozapine. Clozapine is a D1 and D4 receptor blocker. It doesn't work that very much on D2 receptors, and maybe that might be a reason that the side effects like extrapyramidal side effects and hyperprolactinemia are less. Extrapyramidal side effects are usually the Parkinson's type side effects. So like shaking, small step gait. So these are a little bit like Parkinson's type side effects. Clozapine has lots of, so it's not a pure drug, has lots of work on neurotransmitter, has some anticholinergic, anti always means blocking, antihistaminergic, anti-adrenergic activity, so which then says, causes some of the side effects. I'll come to the side effects later. Some people say that these mixed effects, including the blockade of the serotonergic receptors, are the cause of the efficacy. Some people say that there's increased turnover of GABA in the nuclear accumbens. However, that's difficult because at the end of the day, the question is, it's not totally clear what effects of the medication really cause the antipsychotic effect, which is true for most of the antipsychotics. Right. When you give it, it's quickly absorbed orally. You can take it with food or without food. It's quite quickly metabolized in the liver, which causes what we call first pass effect. So only 50% or even less reaches the circulation into the blood flow. There's quite a few influences from other medications on the metabolism of the clozapine. So smoking activates the liver mitochondrial system and hence reduces the clozapine levels. Age, gender, and changes in the gastric absorption can influence the state of the medication or the amount of medication which goes into the blood. Right. Usually, when it's taken, you get a steady state after 7 to 10 days, which means it takes quite a while for the medication to work, and the medication doesn't work very, very quickly. Right, the half-life is 6 to 33 hours, so when it's in the system, it takes a while to get out. When you start the medication with clozapine, first you start, because of the sedation, with low medication, but then on the other hand, it takes some time for the antipsychotic effect to come in. So usually you start low, and on the other hand, you usually need some time. So it's not a fast medication. It has some interaction with other medication and lithium, such as lithium, which can cause seizures, muscle problems. It can have, clozapine can interact with acetylcholine esterase inhibitors, which are anti-dementia drugs. I mentioned smoking. I mentioned that, or I didn't mention that caffeine can increase the plasma concentrations, and usually you wouldn't want to give medication in patients who have a history of neutropenia or a problem with the white blood cells. It can cause, clozapine can cause pericarditis, myocarditis, and cardiomyopathy. So in people who have a previous history of heart problems, it's always a bit of a problem. So other medications can cause interactions. If you think of alcohol, histaminergic system, H1 blockers, opiate agonists, anxiolytics, so all the medication which sedate, like tramadol or tricyclics, can increase drowsiness, can cause severe sedation, dizziness, and falling. Other medication, which, like chemotherapy, which reduces the development of so white blood cells, wouldn't be given. So there might be some increasing side effects. There's some medication which work on the CYP1A2 and CYP1A CYP2D6 receptors. CYP usually stands for I'll come back to that. Cytochrome. So cytochrome proteins. So that's what's mentioned. Sorry, just a bit of a block here. So CYP means for cytochrome P protein, and the 1A2 is a subreceptor of that. Right, so medication which can affect the CYP1A2 and CYP2D6 receptors, like cimetidine, clarithromycin, ciprofloxacin, fluoxamine, and such as haloperidol, paroxetine, can influence the medication. So if you take other medication and you take clozapine, you have to check with your GP, and the GP has to check the BNF, which is a British National Formulary. Other medication which bind to the proteins in the blood, like digoxin, heparin, can also affect the clozapine levels. I said, it's sedating, so it has anticholinergic effects, so tricyclic antidepressants, for example, or antimuscarinic drugs. Muscarinic drugs should be taken. And because it just reduces the blood pressure, medication which reduces blood pressures can have interactions as well. So that's my talk about clozapine, and I think we have to come back to this to go into more details later. Thanks for that, and thanks for your interest.